Welcome to Board Pearls. This is episode 2 of 3 of the portal hypertension and cirrhosis complications chapter in the liver disease module. This episode is the splanchnic vasodilation cluster, ascites with diuretic management, and the tips versus serial paracentesis decision, hyponatremia, spontaneous bacterial peritonitis with the antibiotic plus albumin bundle, hepatorenal syndrome with terlipressin and albumin, and hepatic encephalopathy with lactulose plus rifaximin. Every complication here flows from the same upstream physiology, and naming it first makes the rest follow. Portal hypertension drives splanchnic arterial vasodilation through nitric oxide excess, the splanchnic bed dilates, the systemic circulation underfills, and the kidney reads that as effective hypovolemia, so the sodium-retaining hormones activate and the kidney avidly retains sodium and water. The patient develops ascites because the kidney has been recruited to retain sodium and water follows. The same underfilling drives the renal vasoconstriction that is hepatorenal syndrome waiting to happen. The same gut translocation that primes ascites for infection produces spontaneous bacterial peritonitis. And the same shunting that decompresses portal pressure bypasses hepatic ammonia clearance to produce encephalopathy. So one physiology produces 4 complications, each with its own bundle, threshold, and drug sequence. Start with ascites, the entry point. The diagnostic step is paracentesis, and the calculation that anchors it is the serum ascites albumin gradient, serum albumin minus acidic albumin, where a gradient over 1.1 supports portal hypertension with high accuracy, while a gradient under 1.1 points toward peritoneal carcinomatosis, tuberculous peritonitis, or pancreatic ascites. The mechanism is that portal hypertension forces protein pore fluid into the peritoneum against a steep oncotic gradient, so the serum holds its albumin while the ascites stays dilute and the difference is large, while non-portal ascites is exudative and the gradient narrows. A refinement is the acidic protein. Low protein under 2.5 with a high gradient fits cirrhotic ascites, while high protein with a high gradient suggests heart failure or constrictive pericarditis, because in cardiac ascites the sinusoidal architecture is preserved, and the sinusoids keep leaking protein-rich plasma, with elevated jugular venous pressure, the clinical anchor. An elevated amylase suggests pancreatic ascites. A high adenosine deaminase tuberculous peritonitis, and cytology evaluates for malignancy. Treatment targets the upstream sodium retention rather than the downstream fluid, with the foundation being sodium restriction under 2 grams a day, and fluid restriction reserved for a serum sodium under 125, because restricting water in a normonatremic patient buys nothing. The backbone is spironolactone plus furosemide in a fixed 100:40 ratio, starting at 100 plus 40 and maxing at 400 plus 160, and the ratio isn't arbitrary because cirrhotic ascites is dominated by secondary aldosteronism. So spironolactone is the primary natriuretic, while furosemide is the adjunct preventing the hyperkalemia and alkalosis spironolactone alone would produce, delivering near-equivalent natriuresis without the hyperkalemia loop diuretics alone cause, so disrupting the ratio in either direction where 2 drug classes are forbidden for mechanistic reasons. NSAIDs inhibit the prostaglandin-mediated renal perfusion that was compensating for the vasoconstricted kidney, and aminoglycosides add direct tubular toxicity to a kidney with no reserve, both converting acute kidney injury into hepatorenal syndrome. Large volume paracentesis above 5 liters needs albumin replacement at 6 to 8 grams per liter removed because of post-paracentesis circulatory dysfunction. The intra-abdominal pressure supporting splanchnic venous return is suddenly removed, the bed expands, effective volume drops, and the underfilling is unmasked, so albumin restores oncotic pressure and volume in one intervention, while crystalloid doesn't substitute because it redistributes and worsens dilutional hyponatremia, and half-dose albumin doesn't substitute either, so an 8-liter tap gets about 50 to 60 grams. That brings refractory ascites, where management changes. The criteria split it into diuretic resistant, failing on maximum tolerated doses with adequate sodium restriction or recurring rapidly after paracentesis, and diuretic intractable, where the patient develops complications on diuretics that prevent effective dosing, hyponatremia under 125, kidney injury, hyperkalemia, or encephalopathy, and both transition the patient out of medication titration into the tips versus paracentesis decision. A common pseudo-refractory pattern is the patient who appears to fail diuretics but has a urine sodium over 80 and is still gaining weight, who isn't diuretic resistant. They're non-adherent to the sodium restriction, so counseling and rechecking answers the question before escalating. The TIPS versus paracentesis decision is organized by mechanism. TIPS creates a controlled portosystemic shunt that lowers portal pressure across the whole system, reducing ascites recurrence and possibly improving transplant-free survival in selected patients. But the same shunt bypasses hepatic ammonia clearance and raises right heart preload, so every contraindication traces to that trade-off. A MELD over about 20, a high bilirubin or INR, recurrent encephalopathy, heart failure, and moderate to severe pulmonary hypertension all arguing against it, with a pre-TIPS echocardia. Encephalopathy after TIPS is the most predictable complication, so rifaximin is started before and continued for months after to reduce ammonia-producing bacteria, and a smaller diameter underdilated shunt further reduces the risk through partial rather than complete pressure reduction. When TIPS is contraindicated or declined, the alternative is scheduled large volume paracentesis every 2 to 4 weeks with albumin, a serviceable strategy that avoids the shunt's trade-offs, with transplant the definitive answer running in parallel. A few things not on the algorithm. Peritoneal venous shunts are largely abandoned for their complications, midodrine doesn't substitute for TIPS or paracentesis, and the vasopressin antagonist tolvaptan treats hyponatremia but doesn't modify ascites because it doesn't address sodium retention and carries a hepatotoxicity warning. Routine maintenance albumin sits in evolving territory, with one trial showing an outpatient survival benefit and another showing none, so current guidance doesn't endorse it routinely, and albumin remains indicated for spontaneous bacterial peritonitis, hypovolemic hyponatremia, and kidney injury as the volume expander of choice. Hyponatremia and cirrhosis is threshold-driven, and the threshold tracks mortality. The mechanism is non-osmotic antidiuretic hormone release from the vasodilation and effective hypovolemia. So the hyponatremia is hypervolemic and dilutional, and it tracks hemodynamic dysfunctions so well that it was added to the transplant allocation score. The action thresholds are concrete. Sodium under 130, reduce the diuretics. Under 125, stop them and fluid restrict under 1500 milliliters. Under 120, admit for saline and free water restriction, and correction paced no faster than 8 to 10 per 24 hours because rapid correction risks osmotic demyelination. Hyponatremia also worsens encephalopathy by adding astrocyte osmotic stress on top of the hyperammonemic edema, so correcting it often softens encephalopathy. And beta blockers and refractory ascites sit in nuanced territory. The old teaching was that they were contraindicated, but current guidance keeps carvedilol as generally tolerated and holds the others when systolic pressure drops under 90, sodium falls under 130, kidney injury develops, or immediately after peritonitis, because the cardiac output reduction in an already vasodilated patient can precipitate kidney injury, so the drug is held and resumed after the physiology resolves. That sets up spontaneous bacterial peritonitis, the infectious complication on top of ascites, whose diagnostic threshold is a single number independent of culture or symptoms. An acidic neutrophil count over 250 per cubic millimeter diagnoses it. Culture-negative nutracetic ascites is treated identically because culture is positive in only half to 4/5 of true cases. The inoculum often small and partially controlled by the time of the tap. So awaiting culture is a critical error since each hour of delay raises mortality. And the rule is paracentesis first, then immediate empiric antibiotics if the count crosses the threshold. Empiric therapy is a third-generation cephalosporin, ceftriaxone or cefotaxime, for 5 to 7 days, covering the dominant organisms, E. coli, Klebsiella, and pneumococcus, without unnecessarily broad coverage, while nosocomial or healthcare-associated or septic cases shift to a carbapenem for resistant gram-negatives, and vancomycin monotherapy is wrong because it misses the dominant pathogens. A repeat tap at 48 hours documents response, targeting a 25% or greater neutrophil reduction, and failure prompts suspicion of resistance or secondary bacterial peritonitis, whose distinction is a board favorite because management diverges. The criteria flagging secondary peritonitis are an acidic glucose under 50, a protein over 1, and an LDH over the serum limit, and 2 of those, plus a polymicrobial gram stain or very high counts, point to bowel perforation, so the next step is urgent imaging and search. The albumin schedule has been unchanged for decades, 1.5 grams per kilogram on day 1 and 1 gram per kilogram on day 3, because the infection precipitates further vasodilation that drops effective volume and triggers hepatorenal syndrome, so albumin restores oncotic pressure and binds inflammatory cytokines, blunting the cascade, and it substantially reduces hepatorenal syndrome and mortality, with the benefit concentrated in patients with a creatinine over 1, a BUN over 30, or a bilirubin over 4, so waiting for the creatinine. Secondary prophylaxis after a first episode is mandatory because the 1-year recurrence rate exceeds 70% without it. Using daily oral norfloxacin, ciprofloxacin, or trimethoprim sulfamethoxazole indefinitely until ascites resolves, transplant, or death, with intermittent dosing producing subtherapeutic levels and resistance. Primary prophylaxis lives in 2 settings. The cirrhotic admitted with a GI bleed gets ceftriaxone for a week, reducing mortality, infection, and rebleeding because translocation during the hemorrhage seeds ascites and bacteremia, and the patient who's never had peritonitis but carries a high-risk acidic protile, an acidic protein under 1.5 plus a decompensation marker like advanced child class, a rising creatinine or BUN, a low sodium, or a high bilirubin, gets continuous daily prophylaxis. And spontaneous bacterial empyema is the pleural analog, a pleural neutrophil count over 250 in a patient with hepatic hydrothorax, treated with the same agents plus prophylaxis. Hepatorenal syndrome is the renal failure the same physiology produces, split into an acute kidney injury form and a chronic form aligned with the standard injury criteria. The diagnostic core is that it's functional rather than structural, so the kidney looks normal on imaging, the sediment is bland, and the response to fluid is unique. The criteria require cirrhosis with ascites, a creatinine rise of more than 0.3 within 48 hours or more than half within a week, absence of structural disease meaning no significant proteinuria or hematuria, no shock, no nephrotoxin exposure, and no improvement after 2 days of diuretic withdrawal plus albumin at a gram per kilogram, and that albumin trial is what separates it from pre-renal azotemia. So the differential is pre-renal azotemia versus this syndrome versus acute tubular necrosis. Pre-renal has low urine sodium and improves with fluid. This has low urine sodium and doesn't, and tubular necrosis has high urine sodium and granular casts and doesn't improve, and the albumin challenge is the bedside maneuver that pulls it out of the pre-renal column. First-line therapy is terlipressin plus albumin, the terlipressin dosed at just under a milligram every 6 hours, titrated up to a maximum, with albumin 20 to 40 grams daily alongside, continued up to 14 days or to creatinine response, and the mechanism is that it produces splanchnic vasoconstriction, reducing portal flow, shunting blood to the renal circulation, and reversing the upstream mismatch, so it works on the vasodilation that started the cascade. It has 2 boundaries. A respiratory one, because pulmonary vasoconstriction worsens ventilation-perfusion mismatch in patients with intrapulmonary shunting, so it's avoided in hypoxia, and the very sick patient, because with a very high creatinine or MLD, the survival benefit narrows and the respiratory risk widens, and the 14-day course is the ceiling, because extending it adds ischemic toxicity without efficacy, so non-response transitions the patient to renal replacement as a bridge to transplant. When terlipressin is unavailable, norepinephrine in the ICU is an effective alternative, and the ward-based fallback is midodrine plus octreotide plus albumin, inferior but reasonable. TIPS isn't routine for the acute form because it doesn't allow time for pressure-driven recovery, though it may be considered in the chronic form with refractory ascites, and transplant is the only definitive cure, with the patient who fails terlipressin and stays dialysis-dependent for at least 6 weeks meeting simultaneous liver-kidney transplant criteria, because renal recovery after isolated liver transplant becomes unlikely beyond that. NSAIDs and aminoglycosides are forbidden here for the same reasons as in ascites. Hepatic encephalopathy is the cerebral expression of the same shunting, and the gut-to-brain pathway organizes the therapy. Gut-derived ammonia bypasses hepatic detoxification through shunting and crosses into the brain. Astrocytes convert it to glutamine and swell. Cerebral inflammation amplifies the swelling, and concurrent hyponatremia adds osmotic stress, which is why correcting sodium softens it. The grading spans minimal encephalopathy detectable only on testing through coma. First line for an episode is lactulose, 30 to 60 milliliters titrated to 2 to 3 soft stools a day, targeting 2 nodes at once, colonic acidification trapping ammonia as ammonium that can't diffuse back, and the laxative effect reducing transit time and ammonia generation, with rifaximin added after a first overt episode to reduce recurrence by cutting ammonia-producing bacteria, well tolerated long-term because of minimal absorption, and the combination is the supported standard. Precipitant identification is essential because the failed system can usually compensate for baseline ammonia, so an episode signals an added insult. Infection, especially peritonitis, a GI bleed presenting a protein load to gut bacteria. hypokalemia, which raises renal ammoniogenesis and shifts equilibrium toward diffusible ammonia, metabolic alkalosis, which favors the diffusible form, dehydration, constipation, sedatives, especially benzodiazepines and opioids, and renal failure, so the patient who arrives confused, constipated for a week on new oxycodone. Protein restriction is forbidden because skeletal muscle is the largest extrahepatic ammonia detoxifier, so restriction worsens sarcopenia and removes that reservoir, netting more ammonia, so the standard is a high-protein, high-calorie diet with a nighttime snack to interrupt the overnight fast that drives muscle breakdown, with vegetable and dairy protein possibly better tolerated but the dominant message being to feed the patient, and branched-chain amino acids supplementing but never substituting. Minimal encephalopathy is the covert form the bedside exam misses, affecting a substantial fraction of cirrhotics and impairing driving and work despite a normal exam, detected by validated psychometric tests. So a patient with cognitive complaints, a normal exam, and a near-miss driving needs testing rather than reassurance, with treatment improving performance. Naloxone and flumazenil are wrong answers in routine encephalopathy, and empiric dialysis is reserved for severe kidney injury, dialyzable intoxications, or acute liver failure with severe hyperammonemia, not chronic encephalopathy with a reversible precipitant. And TIPS is avoided with prior overt encephalopathy because the shunt expands the same bypass driving it, with transplant evaluation appropriate for refractory disease. So pulling it together, one physiology produces 4 complications, and each targets a specific node. Ascites is treated by blocking the dominant aldosterone signaling with spironolactone supported by furosemide, with refractory ascites transitioning to TIPS or scheduled paracentesis with albumin. Peritonitis is treated with a 3rd-generation cephalosporin and the day 1 and day 3 albumin schedule to block the cascade that drives hepatorenal syndrome. That syndrome is treated by reversing the vasodilation with terlipressin and supporting the circulation with albumin. And encephalopathy is treated by trapping ammonia in the colon with lactulose and reducing its bacterial generation with rifaximin. The thresholds that anchor each decision are mechanism-derived. A neutrophil count over 250 defines peritonitis because it can't be explained otherwise. 6 to 8 grams of albumin per liter removed prevents post-paracentesis circulatory dysfunction. A creatinine rise of 0.3 defines the acute renal syndrome, and a sodium under 125 triggers fluid restriction because below that the dilutional sodium tracks mortality. The next episode covers the cirrhosis complications that don't flow primarily through splanchnic vasodilation, hepatopulmonary syndrome, portopulmonary hypertension, and hepatic hydrothorax on the pulmonary side, the coagulopathy where the INR misleads about bleeding risk and rebalanced hemostasis governs procedures, and the vascular liver diseases like Budd-Chiari and portal vein thrombosis. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 3 of chapter 23, and I'll see you in the next one.